Question 1. The analysis reveals that patient, 5 years post-thoracic surgery for a complex resection, reports subjective shortness of breath during exertion and occasional chest tightness, though immediate postoperative recovery was uneventful and initial follow-up showed no significant issues. What is the most appropriate next step in managing this patient's long-term well-being and potential complications? Option A. Advise the patient to monitor symptoms and report any significant worsening without further immediate investigation. Option B. Schedule serial pulmonary function testing and refer for a comprehensive pulmonary rehabilitation assessment. Option C. Focus on the absence of immediate postoperative complications and consider the current symptoms as unrelated to the prior surgery. Option D. Reassure the patient that symptoms are likely due to deconditioning and advise increased general physical activity. The correct answer is B. Schedule serial pulmonary function testing and refer for a comprehensive pulmonary rehabilitation assessment. Explanation. The scenario presents a common challenge in cardiothoracic surgery, managing the long-term consequences of surgical interventions, specifically focusing on pulmonary function decline and scarring after a complex procedure. The professional challenge lies in balancing the immediate success of the surgery with the patient's long-term quality of life and functional status. This requires a proactive and comprehensive approach to patient care that extends beyond the immediate postoperative period. The correct approach emphasizes a structured, evidence-based follow-up strategy that includes serial pulmonary function testing and a personalized rehabilitation program. This aligns with the American Board of Thoracic Surgery's commitment to lifelong learning and the highest standards of patient care. By systematically monitoring pulmonary function, surgeons can identify early signs of decline, intervene appropriately, and optimize rehabilitation efforts. This proactive management is ethically sound, as it prioritizes patient well-being and aims to maximize functional recovery and minimize the impact of long-term complications. It also reflects a commitment to understanding and mitigating the sequelae of surgical procedures, contributing to the body of knowledge and improving future patient outcomes. An incorrect approach that focuses solely on the absence of immediate postoperative complications fails to acknowledge the dynamic nature of pulmonary recovery and the potential for delayed or progressive decline. This oversight represents a failure in comprehensive patient management and a disregard for the long-term implications of thoracic surgery. Ethically, it falls short of the duty to provide ongoing care and to address all foreseeable complications. Another incorrect approach that relies on patient self-reporting without objective assessment is insufficient. Patient feedback is valuable. It cannot replace objective diagnostic tools like pulmonary function tests. This approach risks underestimating or misdiagnosing the extent of pulmonary compromise, leading to delayed or ineffective interventions. It also fails to meet the standard of care expected in managing complex surgical patients. A further incorrect approach that dismisses the significance of scarring as a purely cosmetic issue overlooks its potential to impact pulmonary mechanics and function. Significant pleural or parenchymal scarring can lead to restrictive lung disease, chronic pain, and reduced exercise tolerance. Ignoring these potential functional consequences is a failure to provide holistic care and to address all aspects of patient recovery. The professional reasoning process for similar situations should involve a thorough understanding of the specific surgical procedure performed, its known long-term sequelae, and the patient's individual risk factors. This includes establishing a clear follow-up plan with defined milestones for objective assessments, such as serial pulmonary function tests. Furthermore, it necessitates a collaborative approach involving multidisciplinary teams, including pulmonologists and rehabilitation specialists, to ensure comprehensive management of long-term complications. Continuous self-education and staying abreast of evolving best practices in postoperative care and rehabilitation are also paramount. Question 2. Operational review demonstrates a patient presenting with a large mediastinal mass causing significant extrinsic compression of the trachea and main bronchi, leading to progressive dyspnea and hypoxemia. The patient's respiratory rate is elevated, and oxygen saturation is borderline despite supplemental oxygen. Given the suspicion of malignancy, what is the most appropriate initial management strategy to ensure patient safety and facilitate definitive diagnosis? Option A. Perform a core needle biopsy of the mediastinal mass under CT guidance without further pre-procedural physiological assessment. Option B. Initiate non-invasive ventilation and obtain a contrast-enhanced CT scan of the chest to fully characterize the mass and its relationship to surrounding structures. Option C. Proceed directly to rigid bronchoscopy for direct visualization and biopsy of the mediastinal mass. Option D. Administer empiric chemotherapy based on the imaging suspicion of malignancy. The correct answer is B. Initiate non-invasive ventilation and obtain a contrast-enhanced CT scan of the chest to fully characterize the mass and its relationship to surrounding structures. Explanation. Scenario analysis. This scenario presents a challenge in managing a patient with a complex thoracic condition, specifically a large mediastinal mass with suspected malignant features, where the diagnostic and therapeutic pathways are intertwined with the patient's overall physiological status. The professional challenge lies in balancing the urgency of diagnosis and potential intervention with the patient's compromised respiratory function, necessitating a nuanced understanding of the pathophysiology of airway compression and its systemic effects. The decision-making process requires integrating clinical assessment, imaging findings, and an understanding of how the mass impacts cardiopulmonary mechanics to formulate a safe and effective management plan. Correct approach analysis. The correct approach prioritizes a multidisciplinary assessment and a staged diagnostic strategy that accounts for the patient's respiratory compromise. This aligns with best professional practice by ensuring patient safety and optimizing diagnostic yield. Specifically, obtaining a CT scan with contrast is crucial for characterizing the mass, assessing its relationship to vital structures, and identifying potential vascular involvement, which directly informs surgical planning and risk stratification. Simultaneously, initiating non-invasive ventilation, NIV, addresses the immediate respiratory distress, improving oxygenation and reducing the work of breathing. This physiological support is paramount before any invasive procedures, as it stabilizes the patient and mitigates the risks associated with anesthesia and potential airway manipulation. This approach is ethically sound, adhering to the principle of beneficence by prioritizing the patient's well-being and minimizing harm. It also reflects a commitment to evidence-based practice by utilizing diagnostic tools that provide comprehensive anatomical and pathological information. Incorrect approaches analysis. Proceeding directly to a rigid bronchoscopy without prior physiological optimization or detailed imaging is a significant regulatory and ethical failure. This approach disregards the patient's compromised respiratory status, creating an unacceptable risk of intraoperative hypoxia, hemodynamic instability, or even airway collapse during instrumentation. It violates the principle of non-maleficence by exposing the patient to undue harm. Furthermore, it represents a failure in due diligence by not obtaining adequate diagnostic information to guide the procedure safely. Performing a core needle biopsy of the mediastinal mass without first assessing the patient's respiratory reserve and providing supportive measures is also professionally unacceptable. Biopsy is essential for definitive diagnosis. Undertaking it in a patient with significant airway compression and respiratory distress without addressing these issues first is dangerous. It risks exacerbating respiratory failure, potentially leading to a medical emergency. This demonstrates a lack of comprehensive patient assessment and a failure to adhere to a stepwise, safety-conscious diagnostic pathway. Administering empiric chemotherapy based solely on imaging suspicion without a definitive tissue diagnosis is premature and potentially harmful. While some mediastinal masses have characteristic imaging appearances, a definitive diagnosis is required to guide appropriate treatment, especially in the context of thoracic malignancies. Empiric treatment can mask the true diagnosis, delay definitive therapy, and expose the patient to unnecessary toxicity if the diagnosis is incorrect. This approach fails to adhere to the fundamental principle of establishing a diagnosis before initiating treatment, which is a cornerstone of medical ethics and regulatory compliance in patient care. Professional reasoning. Professionals should approach such complex thoracic cases by first conducting a thorough assessment of the patient's overall condition, with a particular focus on cardiopulmonary function. This involves integrating clinical signs, symptoms, and available imaging. The next step is to identify and address any immediate physiological derangements that could compromise safety during diagnostic or therapeutic interventions. A multidisciplinary team approach involving thoracic surgeons, pulmonologists, anesthesiologists, and radiologists is crucial for comprehensive planning. Diagnostic strategies should be staged, starting with less invasive methods that provide maximal information while minimizing risk, and progressing to more invasive procedures only after adequate physiological preparation and risk mitigation. This systematic, patient-centered approach ensures that interventions are both diagnostically effective and therapeutically safe, aligning with ethical obligations and professional standards. Question 3. Research into the optimal imaging strategy for a patient presenting with a complex, indeterminate pulmonary nodule and suspected mediastinal lymphadenopathy, considering the need for accurate staging and treatment planning, leads to a critical decision point regarding the initial diagnostic approach. Option A. Proceed directly to a magnetic resonance imaging (MRI) scan of the chest to evaluate the extent of the lesion and potential vascular involvement. Option B. Obtain a contrast-enhanced computed tomography (CT) scan of the chest, followed by a positron emission tomography computed tomography (PET-CT) scan if the CT suggests malignancy or indeterminate findings requiring metabolic assessment. Option C. Order a PET-CT scan as the initial imaging modality to assess the metabolic activity of the nodule and any enlarged lymph nodes. Option D. Perform a chest X-ray followed by an ultrasound of the mediastinum to assess for lymphadenopathy. The correct answer is B. Obtain a contrast-enhanced computed tomography (CT) scan of the chest, followed by a positron emission tomography computed tomography (PET-CT) scan if the CT suggests malignancy or indeterminate findings requiring metabolic assessment. Explanation: this scenario presents a professional challenge due to the need to balance diagnostic accuracy with patient safety and resource utilization, particularly when evaluating a complex thoracic condition. The physician must critically assess the strengths and limitations of various imaging modalities in the context of the patient's specific clinical presentation and potential underlying pathology. The decision-making process is further complicated by the evolving landscape of imaging technology and the imperative to adhere to established guidelines and best practices, ensuring that diagnostic choices are evidence-based and clinically justified. The correct approach represents best professional practice by prioritizing a systematic and evidence-based selection of imaging modalities. This involves considering the specific diagnostic question, the suspected pathology, and the known capabilities of each modality. For a suspected complex thoracic mass with potential vascular or nodal involvement, a contrast-enhanced CT scan is often the initial and most appropriate choice due to its excellent spatial resolution, ability to delineate soft tissues, and assessment of vascularity and lymphadenopathy. Subsequent imaging, such as PET-CT, is then judiciously employed based on the findings of the initial CT to assess metabolic activity and guide further management, such as biopsy or treatment planning. This approach aligns with established guidelines for thoracic imaging, emphasizing the judicious use of resources and avoiding unnecessary radiation exposure or cost. An incorrect approach would be to indiscriminately order multiple advanced imaging studies without a clear clinical rationale. For instance, proceeding directly to a PET-CT scan without an initial contrast-enhanced CT would be a regulatory and ethical failure. PET-CT is primarily a functional imaging modality and is less effective than CT for detailed anatomical assessment of thoracic structures, especially for initial characterization of a mass. Its use is typically reserved for staging, assessing metabolic activity of known lesions, or evaluating treatment response after anatomical detail has been established. Similarly, ordering an MRI without a clear indication, such as suspected mediastinal invasion or specific soft tissue characterization not adequately addressed by CT, would represent a failure to adhere to best practices and could lead to unnecessary costs and patient inconvenience. The regulatory framework implicitly supports efficient and effective patient care, which includes selecting the most appropriate diagnostic tool for the specific clinical question, thereby avoiding wasteful expenditure and potential patient harm from over-investigation. The professional reasoning process should involve a thorough clinical assessment, formulation of a differential diagnosis, and then a strategic selection of imaging modalities that will most effectively answer the diagnostic questions while minimizing risks and costs. This requires a deep understanding of the strengths and weaknesses of CT, MRI, and PET-CT in evaluating thoracic pathology, and a commitment to evidence-based medicine and established clinical guidelines. Question 4. Examination of the data shows a 68-year-old male presenting with progressive exertional dyspnea and chest discomfort, New York Heart Association Class Roman III, refractory to optimal medical therapy. Cardiac catheterization reveals severe triple-vessel coronary artery disease with a significantly reduced ejection fraction, 30%, and evidence of prior myocardial infarction in the inferior wall. Echocardiography suggests moderate hypokinesis of the inferior and posterior segments, with preserved systolic function in the anterior and lateral walls. The patient has a history of type 2 diabetes mellitus, hypertension, and moderate renal insufficiency. What is the most appropriate next step in management? Option A. Proceed with coronary artery bypass grafting, CABG, after optimizing medical management for diabetes and renal function. Option B. Refer for percutaneous coronary intervention, PCI, of the most severely stenosed vessels, prioritizing those supplying viable myocardium. Option C. Evaluate for advanced heart failure therapies, including cardiac resynchronization therapy or mechanical circulatory support, given the reduced ejection fraction. Option D. Initiate aggressive medical management with beta blockers, ACE inhibitors, and statins, and consider serial stress testing. The correct answer is A. Proceed with coronary artery bypass grafting, CABG, after optimizing medical management for diabetes and renal function. Explanation. This scenario presents a common yet complex clinical challenge in cardiothoracic surgery, requiring a nuanced understanding of ischemic heart disease pathophysiology and its implications for surgical decision-making. The professional challenge lies in balancing the immediate need to address severe ischemic symptoms with the long-term risks and benefits of various interventions, particularly in a patient with significant comorbidities. Careful judgment is required to select the most appropriate management strategy that optimizes patient outcomes while adhering to established clinical guidelines and ethical principles. The correct approach represents best professional practice because it prioritizes a comprehensive, evidence-based evaluation of the patient's cardiac status and overall health. This involves a multidisciplinary assessment, including detailed hemodynamic evaluation, assessment of myocardial viability, and consideration of the patient's functional capacity and risk profile. Such an approach aligns with the American Board of Thoracic Surgery's emphasis on rigorous patient selection and the application of sound clinical judgment informed by current scientific knowledge and ethical considerations. It ensures that interventions are tailored to the individual patient's needs and that the risks are carefully weighed against the potential benefits, thereby upholding the principle of beneficence and non-maleficence. An incorrect approach that focuses solely on immediate symptom relief without a thorough assessment of underlying pathophysiology or patient risk would be professionally unacceptable. This could lead to inappropriate interventions, potentially causing harm or failing to address the root cause of the patient's condition. For instance, proceeding with a revascularization strategy without confirming significant myocardial ischemia or assessing viability might result in unnecessary surgical risk and morbidity. Another incorrect approach might involve delaying definitive management due to patient comorbidities without a clear plan for optimizing their condition, potentially leading to worsening ischemia or adverse cardiac events. These approaches fail to adhere to the ethical imperative of providing the highest standard of care and may violate guidelines that mandate thorough preoperative evaluation and risk stratification. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly review all available clinical data, including history, physical examination, diagnostic imaging, and laboratory results. 2. Identify the primary pathophysiological derangements and their clinical significance. 3. Consider the patient's overall health status, including comorbidities and functional capacity. 4. Evaluate potential management options, weighing the risks, benefits, and alternatives for each. 5. Consult with relevant specialists to ensure a multidisciplinary perspective. 6. Engage in shared decision-making with the patient and their family, ensuring they understand the rationale for the recommended treatment plan. 7. Document the decision-making process meticulously. Question 5. The evaluation methodology shows a postoperative thoracic surgery patient exhibiting significant paradoxical chest wall motion and persistent dyspnea, raising concerns about diaphragmatic paralysis and thoracic instability following a complex oncologic resection. The surgical team is debating the optimal next steps for management and rehabilitation. Which of the following strategies best reflects a comprehensive and evidence-based approach to address these complex postoperative challenges? Option A. Initiate a structured pulmonary rehabilitation program focusing on diaphragmatic breathing exercises and progressive chest wall strengthening, coordinated with respiratory therapy for ventilatory support optimization and weaning. Option B. Rely primarily on serial chest imaging to monitor for changes in diaphragmatic position and thoracic wall integrity, with pharmacological management of dyspnea as the main therapeutic strategy. Option C. Proceed with immediate surgical intervention to stabilize the thoracic wall and consider diaphragmatic plication, deferring extensive rehabilitation until postoperative recovery is complete. Option D. Focus on aggressive weaning from mechanical ventilation and early ambulation, assuming that functional improvement will naturally follow without specific interventions for diaphragmatic or thoracic wall mechanics. The correct answer is A. Initiate a structured pulmonary rehabilitation program focusing on diaphragmatic breathing exercises and progressive chest wall strengthening, coordinated with respiratory therapy for ventilatory support optimization and weaning. Explanation. The evaluation methodology shows a scenario where a thoracic surgeon is faced with a complex case involving diaphragmatic dysfunction and potential thoracic wall instability following a major oncologic resection. The professional challenge lies in balancing immediate postoperative management with long-term functional recovery and patient quality of life, all while adhering to established surgical standards and patient safety protocols. This requires a nuanced understanding of diaphragmatic physiology, biomechanics of the thoracic cage, and the potential sequelae of surgical intervention. The correct approach, which involves a multidisciplinary assessment including respiratory therapy and physical medicine and rehabilitation, represents best professional practice because it aligns with the American Board of Thoracic Surgery's emphasis on comprehensive patient care and evidence-based management. This collaborative strategy ensures that all aspects of the patient's recovery are addressed, from ventilatory support and weaning to optimizing thoracic wall mechanics and diaphragmatic function. Such an approach is ethically sound, prioritizing patient well-being and functional outcomes, and is implicitly supported by guidelines promoting interdisciplinary care in complex surgical cases. An incorrect approach that focuses solely on aggressive weaning from mechanical ventilation, without adequate assessment of diaphragmatic strength and thoracic wall integrity, would be professionally unacceptable. This failure to consider the biomechanical interplay between the diaphragm and thoracic wall could lead to prolonged respiratory distress, increased risk of reintubation, and suboptimal functional recovery, potentially violating the principle of beneficence and non-maleficence. Another incorrect approach, such as delaying physical therapy until complete wound healing is achieved, ignores the critical role of early mobilization and diaphragmatic retraining in preventing complications like atelectasias and pneumonia, and in restoring respiratory mechanics. This delay could be seen as a failure to adhere to best practices in postoperative care, potentially leading to poorer long-term outcomes. A third incorrect approach, which involves solely relying on imaging to assess diaphragmatic function without considering clinical parameters and patient-reported symptoms, would be insufficient. While imaging is valuable, it does not capture the dynamic functional capacity of the diaphragm or the patient's subjective experience of dyspnea and chest wall discomfort, thus failing to provide a holistic picture for optimal management. Professional decision-making in such situations requires a systematic evaluation of the patient's clinical status, including respiratory mechanics, diaphragmatic excursion, thoracic wall stability, and overall physiological reserve. This should be followed by a collaborative discussion with the patient and the multidisciplinary team to formulate a personalized management plan that prioritizes safety, functional recovery, and patient-centered goals, all within the framework of established surgical and ethical guidelines. Question 6. To address the challenge of potential neurological injury during complex thoracic interventions, which of the following represents the most critical component of a comprehensive risk assessment strategy? Option A. Proceeding with surgery based primarily on the extent of the thoracic disease, assuming neurological integrity unless specific symptoms are overtly present. Option B, a detailed preoperative evaluation of the patient's neurological status and meticulous correlation of thoracic pathology with adjacent neural structures on imaging, informing surgical planning and intraoperative management. Option C, delegating the entire neuroanatomical risk assessment to a consulting neurologist without direct surgeon integration into the operative plan. Option D, relying solely on general surgical principles, without specific emphasis on the intricate neuroanatomy of the thoracic region. The correct answer is B, a detailed preoperative evaluation of the patient's neurological status and meticulous correlation of thoracic pathology with adjacent neural structures on imaging, informing surgical planning and intraoperative management. Explanation: scenario analysis. This scenario is professionally challenging because it requires a thoracic surgeon to integrate detailed neuroanatomical knowledge into the operative decision-making process for a patient with a complex thoracic pathology. The proximity of critical neural structures to the surgical field necessitates a precise understanding of their location, function, and potential vulnerability during intervention. Failure to adequately assess and account for these neuroanatomical relationships can lead to devastating neurological deficits, impacting patient outcomes and potentially leading to litigation. The challenge lies in balancing the need for definitive thoracic treatment with the imperative to preserve neurological function. Correct approach analysis. The correct approach involves a thorough preoperative assessment of the patient's neurological status and a detailed review of imaging studies e.g., CT, MRI, to precisely delineate the relationship between the thoracic pathology and adjacent neural structures, including the spinal cord, sympathetic chain, and phrenic nerve. This understanding informs the surgical plan, guiding the surgeon on optimal surgical approaches, instrument selection, and techniques to minimize the risk of neural injury. Intraoperatively, continuous neuromonitoring, where indicated and meticulous surgical technique are paramount. This approach aligns with the American Board of Thoracic Surgery's emphasis on comprehensive patient care, risk mitigation, and the application of advanced knowledge to ensure patient safety and optimal outcomes, reflecting the ethical obligation to do no harm and to practice within the scope of one's expertise. Incorrect approaches analysis. One incorrect approach would be to proceed with surgery based solely on the thoracic pathology without a detailed preoperative neuroanatomical assessment. This fails to meet the standard of care by neglecting a critical aspect of patient safety and risk assessment. Ethically, it violates the principle of beneficence by not taking all reasonable steps to prevent harm. Legally, it could be construed as negligence. Another incorrect approach would be to rely exclusively on general surgical principles without specific consideration for the unique neuroanatomy of the thoracic region. While general surgical principles are important, they are insufficient when dealing with structures intimately related to the nervous system. This demonstrates a lack of specialized knowledge and a failure to apply it appropriately, which is contrary to the expectations of board certification. A third incorrect approach would be to delegate the neuroanatomical assessment entirely to another specialist without direct surgeon involvement in integrating that information into the surgical plan. While consultation is valuable, the primary surgeon bears the ultimate responsibility for understanding and managing all risks, including those related to neuroanatomy, within their operative field. This abdication of responsibility is ethically and professionally unsound. Professional reasoning. Professionals facing such a scenario should employ a systematic decision-making process. This begins with a comprehensive understanding of the patient's condition, including all relevant anatomical and physiological factors. Next, a thorough risk-benefit analysis must be conducted, specifically identifying potential neurological complications. The surgical plan should then be meticulously crafted to mitigate these risks, incorporating advanced imaging, intraoperative monitoring, and specialized techniques. Finally, continuous intraoperative vigilance and adaptation based on real-time findings are essential. This structured approach ensures that all aspects of patient care are considered, aligning with the highest standards of surgical practice and ethical responsibility. Question 7. Analysis of a 68-year-old male smoker presenting with a new, peripherally located 3 cm lung nodule on CT scan, accompanied by a 2 cm enlarged mediastinal lymph node in the subcarinal region. The patient is experiencing a mild, non-productive cough, but is otherwise asymptomatic. The thoracic surgeon is considering bronchoscopic evaluation. Which of the following approaches is most appropriate for obtaining a definitive tissue diagnosis? Option A. Flexible bronchoscopy with transbronchial biopsy of the peripheral lung nodule without endobronchial ultrasound guidance. Option B. Flexible bronchoscopy with cytology brushings of the peripheral lung nodule. Option C. Rigid bronchoscopy with direct biopsy of the peripheral lung nodule. Option D. Flexible bronchoscopy with endobronchial ultrasound-guided transbronchial needle aspiration, EBS-TBNA, of the subcarinal lymph node, followed by flexible bronchoscopy with targeted biopsy of the peripheral lung nodule. Correct answer is D. Flexible bronchoscopy with endobronchial ultrasound-guided transbronchial needle aspiration, EBS-TBNA, of the subcarinal lymph node, followed by flexible bronchoscopy with targeted biopsy of the peripheral lung nodule. Explanation. This scenario presents a common clinical challenge in thoracic surgery, managing a patient with a suspected endobronchial lesion requiring diagnostic confirmation and potential therapeutic intervention. The professional challenge lies in selecting the most appropriate bronchoscopic technique based on the lesion's characteristics, the patient's condition, and the need for definitive tissue diagnosis while minimizing procedural risks. Careful judgment is required to balance diagnostic yield with patient safety and resource utilization. The correct approach represents best professional practice because it prioritizes obtaining adequate tissue for diagnosis using a method directly suited to the visualized lesion. Flexible bronchoscopy with biopsy, particularly endobronchial ultrasound-guided transbronchial needle aspiration, EBS-TBNA, if lymph nodes are involved, or if the lesion is submucosal, is the standard of care for peripheral or central lung masses and mediastinal lymphadenopathy. This technique offers a high diagnostic yield for malignancy and other pathologies, allowing for accurate staging and treatment planning. Adherence to established guidelines for bronchoscopic procedures, including informed consent and appropriate sedation, is paramount. An incorrect approach would be to proceed with a rigid bronchoscopy solely for diagnostic biopsy of a peripheral lesion, without clear indication for airway control or large tissue procurement. Rigid bronchoscopy is typically reserved for managing airway obstruction, foreign body removal, or situations requiring extensive airway resection or dilation, not routine peripheral lesion biopsy. Another incorrect approach would be to rely solely on cytology brushings for a submucosal lesion, as this often yields insufficient tissue for definitive diagnosis, particularly for interstitial or sarcomatous processes. Further failure would be to perform a transbronchial biopsy without adequate visualization or guidance, increasing the risk of pneumothorax and yielding non-diagnostic samples. These incorrect approaches fail to adhere to best practices for diagnostic yield and patient safety, potentially leading to delayed diagnosis, repeat procedures, and increased morbidity. The professional decision-making process should involve a thorough review of imaging findings, patient history, and physical examination to characterize the lesion. Based on this assessment, the surgeon should consider the likelihood of malignancy, the lesion's location, central VS, peripheral, endobronchial VS, submucosal, and the presence of mediastinal lymphadenopathy. The choice of bronchoscopic modality should then be guided by the need for tissue acquisition, the expected diagnostic yield of each technique, and the associated risks. Consultation with pathology regarding anticipated tissue requirements is also crucial. Question 8. The efficiency study reveals a significant delay in the turnaround time for cardiovascular diagnostic tests, impacting surgical scheduling and patient management. To address this, the department is considering several strategies for optimizing the interpretation process of echocardiograms and cardiac angiograms. Which of the following strategies best aligns with the principles of efficient, accurate, and ethically sound diagnostic practice as expected within the framework of American Board of Thoracic Surgery certification? Option A. Empower senior cardiology fellows to independently interpret all echocardiograms and cardiac angiograms, with a retrospective review by a staff cardiologist only for cases flagged as abnormal. Option B. Implement a multidisciplinary interpretation panel comprising cardiologists, cardiac radiologists, and thoracic surgeons for all complex echocardiograms and angiograms, with a standardized protocol for expedited review of urgent cases. Option C. Prioritize the interpretation of diagnostic tests based solely on the scheduled surgical date, accepting preliminary interpretations from any available physician to expedite reporting. Option D. Delegate the initial interpretation of all echocardiograms to experienced cardiac sonographers, with the final report generated by the attending thoracic surgeon without direct cardiologist or radiologist input. The correct answer is B. Implement a multidisciplinary interpretation panel comprising cardiologists, cardiac radiologists, and thoracic surgeons for all complex echocardiograms and angiograms, with a standardized protocol for expedited review of urgent cases. Explanation: the efficiency study reveals a significant bottleneck in the cardiac catheterization laboratory's workflow, specifically related to the ordering and interpretation of cardiovascular diagnostic tests. This scenario is professionally challenging because it directly impacts patient care timelines, resource allocation, and potentially the accuracy of diagnostic information. Thoracic surgeons, as key stakeholders in cardiovascular diagnostics, must balance the need for timely and accurate information with the efficient use of hospital resources and adherence to established clinical guidelines. The challenge lies in identifying the most effective and compliant method to streamline this process without compromising patient safety or diagnostic quality. The correct approach represents best professional practice by emphasizing a multidisciplinary team-based strategy for test interpretation, grounded in established American Board of Thoracic Surgery (APS) certification guidelines, which implicitly endorse evidence-based medicine and collaborative care. This approach ensures that interpretations are performed by qualified individuals with appropriate expertise, leading to more accurate diagnoses and better-informed treatment decisions. It aligns with the APS focus on comprehensive surgical training that includes diagnostic interpretation and management, promoting a holistic understanding of patient care. Furthermore, it fosters efficient communication and reduces delays, which are critical in cardiovascular medicine. An incorrect approach that relies solely on a single physician's interpretation, regardless of their specialty, fails to meet the rigorous standards expected for APS certification. This can lead to diagnostic errors due to a lack of specialized experience or a narrow perspective. It also creates an inefficient workflow, potentially delaying necessary interventions. Another incorrect approach that involves delegating interpretation to non-physician staff without direct physician oversight or a clear protocol for review and validation is ethically and regulatorily problematic. Such delegation can violate professional practice standards and may not meet the requirements for diagnostic accuracy and accountability inherent in APS certification. It also bypasses the established chain of responsibility for patient care. A third incorrect approach that prioritizes speed over accuracy by accepting preliminary or unverified interpretations directly compromises patient safety and diagnostic integrity, which are paramount in thoracic surgery and are implicitly tested by the APS. This disregard for thoroughness can lead to misdiagnosis and inappropriate treatment, a failure to uphold the highest standards of medical practice. Professional reasoning in such situations requires a systematic evaluation of diagnostic pathways. Professionals should consider the established guidelines for cardiovascular diagnostics, the specific expertise required for accurate interpretation, the potential impact on patient outcomes, and the efficient utilization of resources. Collaboration with cardiology and radiology departments, clear protocols for test ordering and interpretation, and a commitment to continuous quality improvement are essential. The decision-making process should always prioritize patient safety and diagnostic accuracy, ensuring that all interpretations are performed by qualified individuals within a well-defined and efficient system, in line with the comprehensive training and standards expected of APS-certified surgeons. Question 9. The assessment process reveals a thoracic surgeon reviewing a complex case involving a suspected pulmonary nodule. The initial CT scan shows a 2.5 cm lesion in the right upper lobe, with some irregular margins. A subsequent PET scan demonstrates moderate FDG avidity. The surgeon is considering proceeding directly to video-assisted thoracoscopic surgery (VATS) for wedge resection. However, the patient also has a history of sarcoidosis, which can sometimes present with findings that mimic malignancy on imaging. What is the most appropriate next step in the diagnostic workup to ensure optimal patient management? Option A. Initiate empiric treatment for sarcoidosis and reassess the nodule after the treatment course. Option B. Proceed directly to VATS wedge resection based on the combined findings of CT and PET, assuming the likelihood of malignancy is high. Option C. Order a repeat CT scan in 3 months to monitor for any changes in nodule size or characteristics. Option D. Obtain a transthoracic needle aspiration, TTNA, or endobronchial ultrasound, EBUS, guided biopsy of the nodule for definitive histological diagnosis. Correct answer is D. Obtain a transthoracic needle aspiration, TTNA, or endobronchial ultrasound, EBUS, guided biopsy of the nodule for definitive histological diagnosis. Explanation. The assessment process reveals a common challenge in thoracic surgery: the interpretation and application of diagnostic imaging in complex clinical scenarios. This scenario is professionally challenging because it requires the surgeon to integrate multiple pieces of information from various diagnostic modalities, understand their limitations, and make critical decisions that directly impact patient care and outcomes. The pressure to act decisively while ensuring diagnostic accuracy, patient safety, and adherence to established standards of practice is paramount. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of all available diagnostic data. This involves not only recognizing the strengths of each modality, but also understanding their potential weaknesses and the need for correlation. In the context of thoracic surgery, this often means considering the possibility of false positives or negatives and seeking confirmatory evidence when uncertainty exists. Adherence to the American Board of Thoracic Surgery's emphasis on comprehensive knowledge and clinical judgment ensures that decisions are grounded in the best available evidence and patient-specific factors, aligning with the ethical obligation to provide optimal care. An incorrect approach that relies solely on a single diagnostic modality without considering its limitations or seeking corroboration fails to meet the standards of thoroughness expected in thoracic surgery. This can lead to misdiagnosis, delayed treatment, or unnecessary interventions, all of which carry significant ethical and professional implications. Specifically, it may violate the principle of beneficence by not acting in the patient's best interest due to incomplete or misinterpreted information. Furthermore, it could be seen as a failure to exercise due diligence, potentially falling short of accepted standards of care. Another incorrect approach that involves prematurely proceeding to surgical intervention based on equivocal imaging findings, without further investigation or consultation, represents a significant ethical and professional lapse. This disregards the potential for harm associated with invasive procedures and fails to uphold the principle of non-maleficence. It also demonstrates a lack of critical appraisal of diagnostic information and an insufficient commitment to diagnostic certainty before undertaking significant interventions. The professional reasoning framework for such situations involves a multi-step process. 1. Thorough review of all available diagnostic data, including imaging, pathology, and clinical history. 2. Critical evaluation of the strengths and limitations of each diagnostic modality in the specific clinical context. 3. Consideration of differential diagnoses and the likelihood of each. 4. Consultation with colleagues or subspecialists when diagnostic uncertainty exists. 5. Development of a management plan that prioritizes patient safety and diagnostic accuracy, with clear criteria for proceeding to intervention. This systematic approach ensures that decisions are well-informed, ethically sound, and aligned with best practices in thoracic surgery. Question 10. What factors determine the optimal surgical approach for a patient presenting with a complex mediastinal mass, considering both established best practices and individual patient characteristics? Option A. Focusing solely on the size of the mass as the primary determinant for surgical strategy, without considering its location or suspected histology. Option B. Prioritizing the quickest surgical technique available, regardless of the specific pathology or patient's overall health status. Option C. Reliance on the surgeon's personal experience with similar cases from their early career, assuming established techniques remain universally applicable. Option D. A comprehensive preoperative assessment including detailed imaging, pulmonary and cardiac function evaluation, and a thorough review of current evidence-based guidelines for mediastinal mass management. The correct answer is D. A comprehensive preoperative assessment including detailed imaging, pulmonary and cardiac function evaluation, and a thorough review of current evidence-based guidelines for mediastinal mass management. Explanation: this scenario is professionally challenging due to the inherent complexity of managing thoracic conditions, which often involve critical organ systems and require a multidisciplinary approach. The need to optimize patient outcomes while adhering to established surgical standards and patient safety protocols necessitates careful judgment. The correct approach represents best professional practice because it prioritizes evidence-based guidelines and patient-specific factors. This aligns with the American Board of Thoracic Surgery's commitment to ensuring that certified surgeons possess the knowledge and skills to provide high-quality care. Adherence to established protocols, continuous professional development, and a thorough understanding of the patient's individual anatomy, comorbidities, and the specific pathology are paramount. This approach ensures that treatment decisions are not only technically sound, but also ethically responsible, focusing on maximizing benefit and minimizing risk for each unique patient. An incorrect approach that relies solely on historical personal experience without incorporating current evidence-based literature or contemporary guidelines represents a failure to maintain professional competence. This can lead to suboptimal patient care and potentially violate ethical obligations to provide care that meets the current standard of practice. Another incorrect approach that neglects a comprehensive preoperative assessment, including a detailed review of imaging, pulmonary function, and cardiac status, fails to adequately identify potential risks and tailor the surgical plan. This oversight can lead to intraoperative complications and poorer postoperative outcomes, contravening the ethical duty of due diligence. An approach that prioritizes speed of intervention over thoroughness of planning, without considering the nuances of the specific thoracic condition and the patient's overall health, is also professionally unacceptable. This haste can result in misdiagnoses, inadequate preparation, and ultimately, compromised patient safety, which is a fundamental ethical and professional failing. Professionals should employ a decision-making framework that begins with a thorough understanding of the patient's condition and relevant medical history. This should be followed by a comprehensive review of current, evidence-based guidelines and literature pertaining to the specific thoracic pathology. Next, a detailed preoperative assessment, including all necessary diagnostic imaging and functional studies, is crucial. Finally, a multidisciplinary discussion involving relevant specialists, when appropriate, should inform the surgical plan, ensuring that all potential risks and benefits are considered, and that the chosen approach is tailored to the individual patient's needs and circumstances. Question 11. The efficiency study reveals that a 3-month-old infant presents with a complex congenital anomaly of the thorax, characterized by a large diaphragmatic hernia with significant pulmonary hypoplasia and associated cardiac malformations. The surgical team is considering the optimal management strategy. Option A. Proceed with immediate surgical repair of the diaphragmatic hernia and address the cardiac malformations in a staged fashion based on subsequent physiological assessment. Option B. Undertake a comprehensive, staged surgical plan that addresses the diaphragmatic hernia, optimizes pulmonary function, and corrects or palliates the cardiac malformations concurrently or sequentially as indicated by the patient's hemodynamic status and growth. Option C. Recommend palliative care and focus on supportive measures due to the severity of the pulmonary hypoplasia and associated cardiac issues. Option D. Prioritize correction of the cardiac malformations first, then address the diaphragmatic hernia once the patient is hemodynamically stable from the cardiac surgery. Correct answer is A. Proceed with immediate surgical repair of the diaphragmatic hernia and address the cardiac malformations in a staged fashion based on subsequent physiological assessment. Explanation: this scenario presents a common challenge in pediatric cardiothoracic surgery, where a complex congenital anomaly requires a multidisciplinary approach and careful consideration of long-term outcomes. The professional challenge lies in balancing immediate surgical intervention with the potential for future growth and development, as well as the need for ongoing surveillance. The American Board of Thoracic Surgery certification emphasizes a comprehensive understanding of patient management, not just technical surgical skill. The correct approach represents best professional practice because it prioritizes a staged, evidence-based management strategy tailored to the specific anatomical and physiological characteristics of the patient. This aligns with the principles of patient-centered care and the ethical obligation to provide the highest standard of treatment. It also reflects the understanding that congenital anomalies often require lifelong management, necessitating a plan that considers future interventions and potential complications. Adherence to established guidelines for congenital heart disease management, which are implicitly part of the knowledge base tested by the apps, is paramount. An incorrect approach that focuses solely on immediate anatomical correction without considering the functional implications or the need for staged palliation would be professionally unacceptable. This could lead to suboptimal outcomes, increased morbidity, or the need for reintervention sooner than anticipated. Such an approach would fail to meet the standard of care expected of a certified cardiothoracic surgeon, potentially violating ethical principles of beneficence and non-maleficence by not fully considering the patient's long-term well-being. Another incorrect approach might involve delaying definitive management without clear justification, which could also be detrimental to the patient's development and overall health, representing a failure to act in the patient's best interest. The professional reasoning framework should involve a thorough preoperative assessment, including detailed imaging and hemodynamic evaluation, followed by a collaborative discussion with a multidisciplinary team, pediatric cardiologists, anesthesiologists, intensivists, and potentially geneticists. The decision-making process should be guided by established clinical pathways and evidence-based literature, always prioritizing the individual patient's needs and potential for optimal long-term outcomes. This includes anticipating future surgical needs and the impact of the anomaly on the patient's growth and development. Question 12. Regulatory review indicates that a 65-year-old male with a significant smoking history presents with progressive dyspnea, chronic cough, and decreased exercise tolerance. Initial spirometry reveals moderate airflow obstruction consistent with COPD. However, a high-resolution computed tomography HRCT scan shows subtle reticular opacities and honeycombing in the lung bases, raising suspicion for an underlying interstitial lung disease (ILD), in addition to or instead of COPD. Considering the potential for overlapping pathologies, which of the following diagnostic and management approaches best reflects current best practices and regulatory expectations for ensuring accurate diagnosis and optimal patient care? Option A. Proceed directly to surgical lung biopsy to obtain a definitive histological diagnosis, as this is the gold standard for interstitial lung diseases. Option B. Conduct a comprehensive diagnostic workup, including detailed pulmonary function testing with diffusion capacity, DLCO, review of HRCT findings in conjunction with clinical presentation, and consider bronchoscopy with bronchoalveolar lavage, BAL, if further clarification is needed before considering surgical biopsy. Option C. Focus solely on symptomatic management with oxygen therapy and cough suppressants, as the patient's age and smoking history make definitive diagnosis and treatment less critical. Option D. Initiate aggressive bronchodilator therapy and pulmonary rehabilitation based on the spirometry findings, deferring further investigation for ILD unless symptoms significantly worsen. The correct answer is D. Initiate aggressive bronchodilator therapy and pulmonary rehabilitation based on the spirometry findings, deferring further investigation for ILD unless symptoms significantly worsen. Explanation. Scenario analysis. This scenario presents a common clinical challenge where a patient exhibits symptoms suggestive of multiple overlapping lung diseases, specifically COPD and interstitial lung disease (ILD). Differentiating between these conditions is crucial for accurate diagnosis, appropriate treatment selection, and prognosis, as their underlying pathophysiological mechanisms and management strategies differ significantly. The professional challenge lies in interpreting complex clinical data, including imaging, pulmonary function tests, and patient history, to arrive at a definitive diagnosis and guide patient care effectively, while adhering to established diagnostic and treatment guidelines. Correct approach analysis. The correct approach emphasizes a systematic, evidence-based diagnostic process that integrates multiple data points. This aligns with the American Board of Thoracic Surgery, APS, certification's focus on comprehensive patient management and the application of current medical knowledge. Specifically, the emphasis on obtaining a detailed history, performing a thorough physical examination, and utilizing advanced imaging, high-resolution CT, and pulmonary function testing, including DLCO, is paramount. These steps are essential for characterizing the extent and pattern of lung damage, which are critical for differentiating between the obstructive physiology of COPD and the restrictive/diffuse parenchymal changes characteristic of ILD. The correct approach also implicitly acknowledges the need for multidisciplinary input, which is standard practice for complex thoracic conditions. This methodical approach ensures that diagnostic decisions are not based on assumptions, but on objective findings, leading to optimal patient outcomes and adherence to best practices in thoracic surgery and pulmonology. Incorrect approaches analysis. An approach that solely relies on a presumptive diagnosis of COPD based on smoking history and spirometry, without further investigation for ILD, represents a significant diagnostic failure. This bypasses the critical step of ruling out or confirming other contributing pathologies, potentially leading to inappropriate treatment, e.g., aggressive bronchodilator therapy for ILD, and delayed management of the actual underlying condition. Ethically, this constitutes a failure to provide adequate diagnostic workup and could lead to patient harm. An approach that prioritizes invasive procedures like bronchoscopy with biopsy before exhausting less invasive diagnostic modalities like HRCT and PFTs is inefficient and carries unnecessary risks for the patient. While biopsy may be necessary in some ILD cases, it should be a later step after less invasive methods have provided sufficient information or have been inconclusive. This approach fails to adhere to the principle of least harm and efficient resource utilization. An approach that focuses exclusively on symptom management without a definitive etiological diagnosis is professionally inadequate. While symptom relief is important, it does not address the root cause of the patient's respiratory distress. This approach neglects the fundamental responsibility of diagnosing and treating the underlying disease process, which is a core tenet of medical practice and essential for long-term patient well-being. Professional reasoning. Professionals facing such a diagnostic dilemma should employ a structured approach. First, gather comprehensive patient data, including a detailed history of symptoms, exposures, and comorbidities, followed by a thorough physical examination. Second, utilize appropriate diagnostic tools in a logical sequence, starting with less invasive and more informative tests like spirometry and HRCT. Third, interpret the findings in the context of the patient's overall clinical picture. Fourth, consider multidisciplinary consultation when the diagnosis is complex or uncertain. Finally, formulate a treatment plan based on the confirmed diagnosis, continuously reassessing the patient's response and adjusting management as needed. This systematic process ensures accurate diagnosis, appropriate treatment, and adherence to ethical and professional standards of care. Question 13. The risk matrix shows a patient presenting with acute onset pleuritic chest pain and shortness of breath. Considering the potential for life-threatening thoracic conditions, which initial laboratory test selection best balances diagnostic yield for common critical differentials with efficient resource utilization? Option A, only a complete blood count and basic metabolic panel. Option B, complete blood count, basic metabolic panel, cardiac biomarkers, and arterial blood gas analysis. Option C, only cardiac biomarkers and arterial blood gas analysis. Option D, genetic markers for rare lung diseases and extensive autoimmune panels. The correct answer is B, complete blood count, basic metabolic panel, cardiac biomarkers, and arterial blood gas analysis. Explanation: scenario analysis. This scenario presents a common clinical challenge where a patient exhibits symptoms suggestive of a serious thoracic condition, necessitating prompt and accurate diagnosis. The professional challenge lies in selecting the most appropriate initial laboratory tests to guide further investigation and management, balancing diagnostic yield with resource utilization and patient burden. The urgency of potential life-threatening conditions in thoracic disease requires a systematic and evidence-based approach to diagnostic testing. Correct approach analysis. The correct approach involves ordering a panel of laboratory tests that are highly sensitive and specific for common and critical thoracic pathologies, such as infection, inflammation, and cardiac compromise. This includes a complete blood count, CBC, to assess for infection or anemia, basic metabolic panel, BMP, to evaluate electrolyte balance and renal function which can be affected by systemic illness, and cardiac biomarkers, e.g., troponin, to rule out acute myocardial infarction, a critical differential diagnosis in patients with chest pain. Arterial blood gas (ABG) analysis is crucial for assessing oxygenation and ventilation, particularly in patients with suspected respiratory failure or pulmonary embolism. This comprehensive initial panel provides a broad yet focused assessment, allowing for efficient triage and guiding subsequent, more specialized investigations. This aligns with the principles of evidence-based medicine and efficient healthcare delivery, as emphasized by professional guidelines for the evaluation of thoracic symptoms. Incorrect approaches analysis. Ordering only a CBC and BMP without cardiac biomarkers, or ABG, would be a significant regulatory and ethical failure. This approach neglects critical differentials for thoracic symptoms, such as acute coronary syndromes and respiratory failure, potentially leading to delayed diagnosis and treatment of life-threatening conditions. This violates the ethical duty to provide comprehensive care and the professional standard of care for evaluating chest pain and respiratory distress. Ordering only cardiac biomarkers and ABG without a CBC and BMP would also be professionally unacceptable. While addressing critical cardiac and respiratory issues, this approach overlooks potential underlying systemic infections or metabolic derangements that could be contributing to or mimicking thoracic symptoms, or that require immediate management. This demonstrates a failure to consider the holistic patient presentation and could lead to misdiagnoses of other serious conditions. Ordering a highly specialized and expensive panel of tests, such as genetic markers for rare lung diseases or extensive autoimmune panels, as the initial diagnostic step for undifferentiated thoracic symptoms would be a failure in resource stewardship and potentially a violation of guidelines promoting cost-effective care. While these tests may be relevant in specific contexts, they are not indicated as first-line investigations for a broad range of thoracic presentations and could lead to unnecessary patient anxiety and financial burden without providing immediate diagnostic utility for the most common and urgent conditions. Professional reasoning. Professionals should approach the evaluation of thoracic symptoms with a structured, stepwise diagnostic process. This begins with a thorough history and physical examination to generate a differential diagnosis. Based on this initial assessment, a tiered approach to laboratory testing is employed, starting with broad-spectrum tests that address the most common and life-threatening conditions. The results of these initial tests then guide the selection of further, more specific investigations. This systematic approach ensures efficient use of resources, minimizes patient discomfort, and prioritizes the timely diagnosis and management of critical illnesses, adhering to professional standards and ethical obligations. Question 14. The evaluation methodology shows a 68-year-old male with a history of moderate COPD and a 40-pack-year smoking history presenting with a 2.5 cm peripheral lung nodule suspicious for malignancy. The nodule is located in the right upper lobe, easily accessible via VATS. The patient is otherwise functional and motivated for minimally invasive surgery. The surgeon is experienced in VATS for benign lesions and wedge resections, but has performed fewer lobectomies via VATS compared to open thoracotomy. Considering the patient's COPD, what is the most appropriate next step in managing this patient's surgical candidacy for VATS lobectomy? Option A. Schedule the patient for a bronchoscopy with biopsy to definitively diagnose the nodule before considering surgical approach. Option B. Defer the decision to the patient and his family, providing them with general information about VATS and open surgery without a specific recommendation. Option C. Proceed with VATS lobectomy after optimizing his COPD management and obtaining a thorough cardiopulmonary evaluation to confirm his fitness for VATS. Option D. Recommend an open thoracotomy lobectomy due to the patient's COPD and the surgeon's relative inexperience with VATS lobectomies in such complex cases. The correct answer is C. Proceed with VATS lobectomy after optimizing his COPD management and obtaining a thorough cardiopulmonary evaluation to confirm his fitness for VATS. Explanation. The evaluation methodology shows a scenario where a surgeon is considering video-assisted thoracoscopic surgery, VATS, for a patient with a complex medical history. This scenario is professionally challenging due to the inherent risks associated with VATS, particularly in patients with comorbidities, and the need to balance potential benefits against these risks. Careful judgment is required to ensure patient safety and optimize outcomes, aligning with the American Board of Thoracic Surgery's emphasis on evidence-based practice and patient-centered care. The correct approach represents best professional practice by prioritizing a thorough, individualized assessment of the patient's suitability for VATS. This includes a comprehensive review of their medical history, pulmonary function, cardiac status, and the specific characteristics of the thoracic pathology. The decision to proceed with VATS should be based on established guidelines and evidence demonstrating its safety and efficacy in similar cases, while also acknowledging the surgeon's experience and the available resources. This aligns with the ethical principle of beneficence and non-maleficence, ensuring that the chosen surgical approach maximizes potential benefit while minimizing harm, as expected by the APS certification standards. An incorrect approach that involves proceeding with VATS without a complete preoperative assessment would represent a significant regulatory and ethical failure. This bypasses the fundamental requirement for due diligence in patient care, potentially leading to unforeseen complications and adverse outcomes. Ethically, it violates the principle of informed consent, as the patient cannot make a truly informed decision without a full understanding of their risks and benefits. From a regulatory standpoint, it could be seen as a deviation from accepted standards of care, potentially leading to disciplinary action or legal repercussions. Another incorrect approach, opting for a more invasive open procedure solely due to a perceived lack of personal experience with VATS in complex cases, without objectively evaluating the patient's suitability for VATS, also presents ethical concerns. While surgeon experience is a factor, an absolute refusal to consider VATS when evidence suggests it could be a less morbid option for the patient, without a clear, documented rationale based on patient-specific contraindications, could be seen as failing to act in the patient's best interest. This might also be viewed as a failure to maintain currency with evolving surgical techniques and evidence, which is implicitly expected of certified thoracic surgeons. A third incorrect approach, deferring the decision entirely to the patient's family without providing a clear, evidence-based recommendation and explanation of the risks and benefits, is also professionally unacceptable. While patient autonomy is paramount, the surgeon has a professional and ethical obligation to guide the decision-making process with their expertise. Abdicating this responsibility undermines the patient's ability to make an informed choice and fails to uphold the surgeon's role as a trusted medical advisor. Professional decision-making process for similar situations should involve a systematic evaluation. First, a thorough review of the patient's clinical data and imaging. Second, an assessment of the specific thoracic pathology and its amenability to VATS. Third, a critical appraisal of the available evidence supporting VATS in this context, considering patient comorbidities. Fourth, a frank discussion with the patient and their family about the risks, benefits, and alternatives, including the surgeon's experience and any limitations. And finally, a shared decision-making process that prioritizes the patient's values and preferences while ensuring the chosen approach is safe and effective. Question 15. The control framework reveals a surgeon performing a mediastinoscopy for suspected lymphadenopathy. During the procedure, a structure is encountered that deviates from the typical anatomical presentation of the superior mediastinum. The surgeon must accurately identify this structure to avoid injury to adjacent vital organs. Which of the following anatomical identifications is most critical for ensuring safe dissection in this region? Option A. Accurate differentiation between the ascending aorta and the aortic arch. Option B. Precise identification of the recurrent laryngeal nerve's course relative to the tracheoesophageal groove. Option C. Confirmation of the inferior vena cava's entry into the right atrium. Option D. Recognition of the thoracic duct's origin from the cisterna chyli. The correct answer is B. Precise identification of the recurrent laryngeal nerve's course relative to the tracheoesophageal groove. Explanation. Scenario analysis. This scenario presents a common challenge in thoracic surgery where anatomical variations or unexpected findings during a procedure necessitate rapid, informed decision-making. The surgeon must accurately identify structures within the mediastinum, a complex anatomical region containing vital organs and major vessels, to avoid iatrogenic injury and ensure patient safety. The challenge lies in the potential for subtle anatomical differences or pathological changes to obscure typical landmarks, requiring a deep understanding of mediastinal anatomy and its variations. Correct approach analysis. The correct approach involves a systematic and precise identification of mediastinal structures based on established anatomical knowledge. This includes recognizing the relative positions of the trachea, esophagus, great vessels, aorta, pulmonary artery, vena cava, phrenic nerves, vagus nerves, and lymph nodes. A thorough understanding of the anterior, middle, and posterior compartments of the mediastinum is crucial. This methodical approach ensures that critical structures are identified and protected, aligning with the American Board of Thoracic Surgery's emphasis on foundational surgical knowledge and patient safety, which are paramount in all regulatory and ethical frameworks governing surgical practice. Incorrect approaches analysis, an approach that relies solely on gross visual identification without considering the precise anatomical relationships or potential variations, risks misidentification. For example, mistaking a dilated azygos vein for a lymph node, or misinterpreting the course of a recurrent laryngeal nerve due to surrounding inflammation or tumor could lead to significant complications. This demonstrates a failure to adhere to the rigorous anatomical knowledge expected of a certified thoracic surgeon, potentially violating standards of care and patient safety guidelines. Another incorrect approach would be to proceed with dissection or intervention without definitively identifying a structure, especially if it appears anomalous. This wait and see, or assume it's normal mentality, is contrary to the principle of due diligence and meticulous surgical technique. Risks inadvertent injury to vital structures, which is a direct contravention of the ethical obligation to minimize harm and the regulatory requirement for competent surgical practice. A third incorrect approach might involve relying on imaging findings alone without correlating them with intraoperative anatomical landmarks. While imaging is invaluable preoperatively, intraoperative anatomy can be dynamic and influenced by surgical manipulation, anesthesia, and patient positioning. Failure to integrate intraoperative findings with anatomical knowledge can lead to errors in judgment. Professional reasoning. Professionals should approach such situations by first recalling the standard anatomical relationships of the mediastinal structures. They should then systematically palpate and visualize these structures, using anatomical planes and known landmarks to orient themselves. If an anomaly is encountered, the surgeon should pause, reassess, and consult anatomical references or colleagues if necessary, prioritizing definitive identification before proceeding. This systematic, knowledge-based, and cautious approach ensures patient safety and upholds the highest standards of surgical practice. Question 16. Quality control measures reveal that a patient scheduled for a complex pulmonary resection has spirometry results showing a forced expiratory volume in 1 second, FEV1, of 65% of predicted, with a forced vital capacity, FVC, of 80% of predicted, and an FEV1/FVC ratio of 0.78. The patient is asymptomatic with a normal physical examination and no significant findings on chest imaging. The PFT report indicates acceptable quality for the maneuver. However, the surgical team has concerns that these values may underestimate the patient's true pulmonary reserve given their functional status. Which of the following represents the most appropriate next step in interpreting these PFTs for surgical decision-making? Option A. Review the full PFT report for specific quality control indicators and reproducibility of key measurements, and correlate these findings with the patient's clinical presentation and functional status to determine if further investigation or repeat testing is warranted. Option B. Proceed with the surgical plan, as the reported FEV1 of 65% predicted is within acceptable limits for most major thoracic procedures, and the patient is asymptomatic. Option C. Immediately order a repeat pulmonary function test, as the discrepancy between the PFT results and the patient's clinical presentation suggests an error in the initial testing. Option D. Focus solely on the FEV1/FVC ratio as the primary indicator of obstructive disease and disregard the absolute FEV1 and FVC values in this context. The correct answer is A. Review the full PFT report for specific quality control indicators and reproducibility of key measurements, and correlate these findings with the patient's clinical presentation and functional status to determine if further investigation or repeat testing is warranted. Explanation. Scenario analysis. This scenario presents a common challenge in thoracic surgery where a patient's pulmonary function test, PFT, results appear discordant with their clinical presentation and surgical plan. The challenge lies in accurately interpreting these PFTs to ensure patient safety and optimize surgical outcomes, particularly when the data might be influenced by various factors. A surgeon must exercise careful judgment to avoid misinterpreting the data, which could lead to inappropriate surgical decisions, delayed recovery, or preventable complications. The responsibility extends to ensuring the PFTs themselves are of sufficient quality for reliable interpretation, as per established guidelines. Correct approach analysis. The correct approach involves a systematic review of the PFT report, focusing on the quality control indicators and the absolute values of key spirometric parameters e.g. FEV1, FVC, FEV1/FVC ratio, in the context of the patient's clinical history, physical examination, and imaging. This aligns with the American Board of Thoracic Surgery's emphasis on evidence-based practice and patient safety. Best professional practice dictates that PFTs must meet established quality standards for reliability. If quality control flags are present, or if the results are inconsistent with the clinical picture, further investigation or repeat testing is warranted before making definitive surgical decisions. This ensures that surgical interventions are based on accurate physiological data, minimizing risks associated with impaired pulmonary function. Adherence to guidelines from professional organizations like the American Thoracic Society (ATS) and the European Respiratory Society (ERS) regarding PFT quality and interpretation is implicitly expected. Incorrect approach is analysis. One incorrect approach is to proceed with the surgical plan solely based on the reported absolute PFT values without scrutinizing the quality control indicators or considering the clinical context. This fails to acknowledge that PFTs are subject to technical variability and patient effort, and that quality control is paramount for reliable interpretation. Ethically, this could be considered a failure to exercise due diligence in patient assessment, potentially leading to harm if the PFTs are inaccurate. Another incorrect approach is to dismiss the PFT results entirely due to a minor discrepancy with the clinical impression, without a thorough review of the report and consideration of potential confounding factors. This disregards valuable objective data that, even if imperfect, can provide crucial insights into pulmonary mechanics. A failure to investigate the discrepancy or seek clarification could lead to overlooking significant pulmonary limitations that would impact surgical risk and management. A third incorrect approach is to rely on a single PFT parameter in isolation, without considering the full suite of spirometric measurements and their interrelationships. This oversimplification can lead to misinterpretations, as different parameters provide complementary information about obstructive versus restrictive lung disease or the severity of impairment. This approach lacks the comprehensive analytical rigor expected in surgical decision-making. Professional reasoning. When faced with potentially discordant PFT results, the professional decision-making process should involve 1. Thoroughly reviewing the entire PFT report, paying close attention to quality control flags and reproducibility. 2. Correlating the PFT findings with the patient's clinical history, symptoms, physical examination, and imaging studies. 3. If discrepancies persist or quality is questionable, consulting with a pulmonary specialist or considering repeat PFTs with careful attention to technique. 4. Documenting the rationale for any surgical decision made in light of the PFT interpretation, including any limitations or uncertainties. This systematic approach ensures that surgical decisions are well-informed, patient-centered, and aligned with the highest standards of care. Question 17. Cost-benefit analysis shows that early, aggressive surgical intervention for suspected thoracic emphysema in a hemodynamically unstable patient with underlying severe COPD and diabetes may offer a faster resolution of sepsis, but at the potential cost of increased perioperative morbidity and mortality. Considering the American Board of Thoracic Surgery's emphasis on patient safety and evidence-based practice, what is the most appropriate initial management strategy? Option A. Administer empiric antibiotics and await spontaneous resolution of the emphysema, as surgical intervention in such a high-risk patient is generally contraindicated. Option B. Proceed immediately to video-assisted thoracoscopic surgery, VATS, for decortication and drainage, as sepsis requires urgent surgical source control. Option C. Initiate broad-spectrum antibiotics, optimize medical management of comorbidities, and obtain detailed imaging to delineate the extent of the emphysema before considering surgical intervention. Option D. Delay surgical intervention until the patient's COPD exacerbation is fully resolved, focusing solely on medical management of the emphysema. The correct answer is C. Initiate broad-spectrum antibiotics, optimize medical management of comorbidities, and obtain detailed imaging to delineate the extent of the emphysema before considering surgical intervention. Explanation: this scenario presents a common clinical challenge in thoracic surgery, managing a patient with a complex infectious disease requiring surgical intervention, where the optimal timing and approach are debated. The professional challenge lies in balancing the immediate need to control infection and prevent further morbidity or mortality against the potential risks associated with surgery in a critically ill or immunocompromised patient. Careful judgment is required to assess the patient's overall stability, the extent and nature of the thoracic infection, and the potential benefits versus risks of different management strategies, all within the framework of established clinical guidelines and ethical considerations for patient care. The correct approach represents best professional practice because it prioritizes a multidisciplinary assessment and a staged management plan tailored to the individual patient's condition. This aligns with the American Board of Thoracic Surgery's emphasis on evidence-based practice and patient-centered care. Specifically, initiating broad-spectrum antibiotics to stabilize the patient, followed by a thorough diagnostic workup to precisely define the extent of infection and identify the causative organism, is crucial. This systematic approach allows for informed decision-making regarding the necessity and timing of surgical intervention, such as drainage or debridement, and the selection of the most appropriate surgical technique. This adheres to the principle of do no harm, by minimizing unnecessary surgical risks while aggressively treating the life-threatening infection. An incorrect approach would be to proceed directly to aggressive surgical intervention without adequate medical stabilization and diagnostic workup. This could lead to increased operative risks, such as uncontrolled bleeding, further dissemination of infection, or failure to achieve source control due to incomplete understanding of the pathology. Ethically, this bypasses the due diligence required to ensure the patient's safety and well-being. Another incorrect approach would be to delay definitive surgical management indefinitely based solely on the patient's comorbidities, without a clear plan for optimizing their condition for surgery or considering less invasive alternatives if appropriate. This could result in progressive deterioration and a worse outcome. A further failure would be to rely on a single specialist's opinion without engaging a multidisciplinary team, potentially overlooking critical aspects of the patient's management and leading to suboptimal care. The professional decision-making process for similar situations should involve a comprehensive assessment of the patient's clinical status, including vital signs, laboratory values, and imaging findings. A thorough history and physical examination are essential. Consultation with infectious disease specialists, critical care physicians, and other relevant subspecialties is paramount. A detailed discussion of the risks, benefits, and alternatives of all management options with the patient and their family, ensuring informed consent, is a non-negotiable ethical and professional requirement. The decision-making process should be iterative, allowing for adjustments based on the patient's response to treatment. Question 18. Strategic planning requires a thoracic surgery department to evaluate the integration of a novel minimally invasive surgical technique for complex pulmonary resections. Which of the following approaches best optimizes the adoption of this new technique while upholding patient safety and institutional standards? Option A. Implement the technique on an ad hoc basis whenever a surgeon feels it is technically advantageous, without a structured data collection or review process. Option B. Immediately incorporate the new technique into the standard armamentarium for all eligible complex pulmonary resections, assuming its inherent superiority based on initial reports. Option C. Initiate a pilot program involving a select group of experienced surgeons to meticulously document outcomes, complications, and learning curves, with a formal review process before broader implementation. Option D. Rely solely on the manufacturer's promotional materials and anecdotal evidence from other institutions to justify its immediate and widespread adoption. The correct answer is C. Initiate a pilot program involving a select group of experienced surgeons to meticulously document outcomes, complications, and learning curves, with a formal review process before broader implementation. Explanation: this scenario presents a common challenge in thoracic surgery, where optimizing surgical technique directly impacts patient outcomes and resource utilization. The professional challenge lies in balancing the pursuit of technical excellence with the practical constraints of a busy surgical service, ensuring that advancements in technique are adopted judiciously and safely. Careful judgment is required to select the most appropriate approach that aligns with evidence-based practice, patient safety, and institutional efficiency. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of a new surgical technique before widespread adoption. This aligns with the core principles of continuous quality improvement and patient safety, mandated by professional bodies and regulatory frameworks governing surgical practice in the United States. Specifically, it adheres to guidelines that emphasize the importance of peer review, data collection, and demonstrated efficacy before implementing novel procedures. This methodical process ensures that any new technique is not only technically feasible, but also demonstrably safe and effective, minimizing risks to patients and optimizing resource allocation. An incorrect approach that involves immediate, uncritical adoption of a new technique without proper validation is professionally unacceptable. This failure represents a disregard for established protocols for surgical innovation and patient safety, potentially violating ethical obligations to provide care that meets the highest standards. Such an approach could lead to suboptimal patient outcomes, increased complications, and inefficient use of hospital resources, all of which are subject to scrutiny under professional and institutional review processes. Another incorrect approach, focusing solely on the perceived technical elegance of a new technique without considering its impact on patient recovery or long-term outcomes, is also professionally flawed. This narrow focus neglects the holistic responsibility of a surgeon to ensure the overall well-being of the patient. It may also overlook potential hidden costs or complexities in patient management that could arise from the new technique, failing to meet the standard of care that encompasses comprehensive patient assessment and management. Finally, an approach that prioritizes personal preference or the desire for novelty over established, evidence-based practices, without a clear rationale or supporting data, is ethically questionable. This can lead to a deviation from best practices and potentially expose patients to unnecessary risks. Professional decision-making in such situations should involve a structured process. First, thoroughly reviewing the existing literature and evidence supporting the new technique. Second, consulting with experienced colleagues and mentors. Third, developing a clear plan for data collection and outcome monitoring if the technique is adopted. And fourth, ensuring that any implementation is consistent with institutional policies and regulatory requirements for surgical innovation. Question 19. Market research demonstrates that patients undergoing complex thoracic procedures often present with multiple comorbidities. In the context of preparing such a patient for a lung resection, which of the following preoperative strategies best aligns with the principles of safe and effective surgical care as expected by the American Board of Thoracic Surgery Certification? Option A. Conduct a comprehensive preoperative assessment to identify and optimize all significant comorbidities, including cardiac, pulmonary, and renal function, in consultation with relevant medical specialists before proceeding with the lung resection. Option B. Delegate the entire preoperative assessment and optimization process to nursing staff, relying on their initial findings without direct physician involvement in the planning of comorbidity management. Option C. Prioritize the optimization of only the most severe comorbidity, such as severe COPD, while neglecting other potentially impactful but less critical conditions like mild hypertension or controlled diabetes. Option D. Initiate the surgical procedure promptly after initial consultation, focusing solely on addressing immediate surgical needs and deferring extensive comorbidity management to the postoperative period. The correct answer is D. Initiate the surgical procedure promptly after initial consultation, focusing solely on addressing immediate surgical needs and deferring extensive comorbidity management to the postoperative period. Explanation. This scenario presents a common challenge in thoracic surgery, where a patient with significant comorbidities requires a complex procedure. The professional challenge lies in balancing the urgency of the surgical intervention with the need for comprehensive risk mitigation through preoperative optimization. Careful judgment is required to ensure the patient's safety and improve surgical outcomes, adhering to established standards of care. The correct approach represents best professional practice because it aligns with the American Board of Thoracic Surgery's emphasis on patient safety and evidence-based medicine. Thorough preoperative assessment, including a detailed history, physical examination, and appropriate diagnostic testing, is fundamental. Optimization of comorbidities, such as managing cardiac, pulmonary, and renal function, directly impacts perioperative morbidity and mortality. This proactive strategy minimizes surgical risks and enhances the likelihood of a successful recovery, reflecting a commitment to the highest standards of patient care as expected by the certification board. An incorrect approach that prioritizes immediate surgical intervention without adequate preoperative optimization would be a significant regulatory and ethical failure. It disregards the principle of do no harm by exposing the patient to unnecessary risks. Failing to address treatable comorbidities before surgery violates established clinical guidelines and best practices, potentially leading to adverse events that could have been prevented. This demonstrates a lack of due diligence in patient assessment and a disregard for the comprehensive nature of surgical care. Another incorrect approach, such as delegating the entire preoperative optimization process to non-physician staff without direct physician oversight, would also be professionally unacceptable. While ancillary staff play a crucial role, the ultimate responsibility for the patient's preoperative assessment and the development of the optimization plan rests with the operating surgeon or their designated physician team. Abdicating this responsibility could lead to critical oversights and a failure to identify or manage key risk factors, contravening the ethical obligation to provide competent medical care. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's overall health status, the risks and benefits of the proposed surgery, and the potential for improvement through preoperative interventions. This requires a collaborative approach involving the surgical team, anesthesiology, cardiology, pulmonology, and other relevant specialists. The goal is to create a personalized optimization plan that addresses the individual patient's needs and maximizes their physiological reserve before undertaking a major thoracic procedure. Question 20. The risk matrix shows a patient with early-stage non-small cell lung cancer, a forced expiratory volume in 1 second, FEV1, of 65% predicted, and a diffusing capacity of the lungs for carbon monoxide, DLCO, of 70% predicted. The tumor is located in the right upper lobe and appears amenable to a standard lobectomy with clear margins. However, the patient also has a history of moderate COPD. Considering the potential for postoperative pulmonary compromise, which surgical approach best balances oncologic efficacy with patient safety? Option A. Proceed with a right pneumonectomy due to the potential for COPD exacerbation. Option B. Recommend a limited resection such as a wedge resection to minimize pulmonary insult. Option C. Defer surgical intervention and pursue palliative chemotherapy given the COPD history. Option D. Perform a right upper lobectomy, carefully assessing intraoperative findings and patient tolerance. The correct answer is D. Perform a right upper lobectomy, carefully assessing intraoperative findings and patient tolerance. Explanation. This scenario presents a common challenge in thoracic surgery, balancing the oncologic goals of a lung resection with the patient's physiological reserve and the surgeon's technical capabilities. The risk matrix highlights the inherent complexities of both lobectomy and pneumonectomy, particularly in a patient with compromised pulmonary function. Careful judgment is required to select the approach that maximizes the chance of successful cancer treatment while minimizing perioperative morbidity and mortality. The correct approach, a carefully considered lobectomy, represents best professional practice by adhering to established oncologic principles for lung cancer resection. A lobectomy is generally the preferred surgical option for early-stage non-small cell lung cancer when it can be performed with clear margins, as it preserves more lung parenchyma than a pneumonectomy. This preservation of lung function is critical for patients with pre-existing pulmonary disease, as indicated by the risk matrix. The decision to proceed with a lobectomy, even with some elevated risk, supported by guidelines from professional thoracic surgery societies, which emphasize the importance of oncologic adequacy while striving for lung-sparing procedures when feasible. This aligns with the ethical principle of beneficence, aiming to provide the greatest benefit to the patient. An incorrect approach would be to proceed with a pneumonectomy without absolute oncologic necessity or a thorough assessment of the patient's ability to tolerate such a significant resection. A pneumonectomy, while sometimes necessary for centrally located tumors or those involving major vascular structures, carries a substantially higher risk of morbidity and mortality, especially in patients with compromised lung function. Ethically, this would violate the principle of non-maleficence by exposing the patient to an unnecessarily high risk of harm. Furthermore, it could be seen as a failure to adhere to evidence-based guidelines that advocate for lung-sparing resections whenever oncologically sound. Another incorrect approach would be to recommend a less invasive procedure, such as a wedge resection or segmentectomy, solely to reduce surgical risk. If the oncologic staging and tumor characteristics clearly indicate that a lobectomy is required for adequate tumor clearance. While minimizing risk is important, compromising oncologic efficacy for the sake of perceived surgical safety would be a failure of professional duty. This would violate the principle of beneficence by not providing the most effective treatment for the patient's cancer, potentially leading to recurrence or progression. It also fails to uphold the standard of care for treating lung cancer. The professional reasoning process for similar situations involves a comprehensive preoperative evaluation, including detailed pulmonary function testing, cardiopulmonary exercise testing, and imaging. This is followed by a multidisciplinary discussion involving thoracic surgeons, medical oncologists, radiation oncologists, and pulmonologists. The surgeon must then weigh the oncologic requirements against the patient's physiological reserve, considering the specific risks and benefits of each surgical approach. Shared decision-making with the patient, ensuring they understand the risks, benefits, and alternatives, is paramount. The decision should be guided by current evidence-based guidelines and the surgeon's experience, always prioritizing the patient's best interest and well-being.